Today, Dr. Vanchiere is going to update us on a couple of very important and how quickly this can change and how important it is to keep up with what's going on, not only in this country but around the world, that may pose potential threats for us.
All right, so as most of you know, infectious diseases is pretty much the one area of medicine that continues to increase every year. We actually have to add things to our courses every year because of the new viruses, new bacteria and the like. And I don't think anatomy has discovered a new bone for a couple of hundred years. So, you know, just in terms of contrast of what's in the course, things change rapidly with infectious diseases. So today I thought we'd update you on some of the emerging threats. I have no disclosures related to the content, and I'm not planning to talk about any off-label use of medications. But if I do, I'll tell you. We're going to look at the epidemiology of some of the current emerging viral pathogens, and especially get into some of the epidemiologic clues and signs and symptoms that distinguish these from things you're more familiar with, and look at the clinical importance of some of our locally endemic infectious diseases, and how that compares to the epidemiology of emerging viral pathogens. I don't know what all that means, but it sounded pretty good. All right, so today we're going to talk a little bit about Ebola. We'll spend about probably half our time with a really update on Ebola, not just the epidemiology, but talk a little bit about the clinical presentation of the patients and the things that are being dealt with in our tertiary referral centers where Ebola patients have been treated. I'll update you a little on the Enterovirus D68 epidemic that is kind of now playing second fiddle to the Ebola epidemic. We'll talk about the Middle Eastern coronavirus because that is a potential threat, and there have been a few cases in the United States. We'll talk about avian influenzas, especially the highly pathogenic and not so pathogenic but more problematic. And then, of course, not to be forgotten, our footnote will be a little bit on where we are on flu and some of our local endemic infections. So that's sort of our outline. All right, so this is a sentence from Dr. Bruce Allward from WHO, kind of summarizes the situation with Ebola. He said, some people have said to me, that's great, there's only a little bit of disease. And I've said, well, that's like saying you're a little bit pregnant. This is Ebola. This is a horrible, unforgiving disease. You've got to get to zero. And this emphasizes the magnitude of the situation, not in terms of numbers, but in terms of the significance for our world and our society, because a mass epidemic of Ebola that spreads worldwide would be extremely problematic, as you will see. This is the data from the CDC up till March 18th of the three main countries, Guinea, Sierra Leone, and Liberia. And you can see Liberia has the highest case count at that point, 4,500 cases. This is in October, and they updated this just 2 days ago to show us the case counts. Now the scale is up to 8,000, and you can see that Liberia and Sierra Leone have almost the same number of cases, and Guinea has a much lower case count. But the number of cases cumulative is continuing to increase. The relatively good news about that is that in each of those three countries, the number of new cases reported per week has already peaked. And so here you can see Liberia, the number of new cases per week peaked here back in October. In Sierra Leone, Guinea, the new cases per week peaked in October also, and then the new cases per week peaked in Sierra Leone recently in late November. So we're beginning, we think, to see the turn of the tide. That is, numbers of cases still continue, but the number of new cases per week is not as heavy of a burden. And there are reports that some of the Ebola treatment centers that have been set up in the past 6 months are now fairly empty, and very few patients presenting in some areas of those countries. Now, if you look at where the epidemic has been the most prevalent, it's down here in Liberia. These are the three countries, Liberia, Sierra Leone, and Guinea, and you can see they're on the western coast of Africa. These are big port cities, which of course means that there's a lot of commerce going on, and they're therefore a perfect setup for a global expansion of the epidemic and of great concern. And this heat map with the greatest cumulative incidence of 300 to 600 patients per 100,000 population. You can see the red is centered here in Liberia, a little fewer cases out into Sierra Leone, and Guinea has had the least number of cases overall. So what does Ebola disease look like? Early on, patients are asymptomatic, usually for a period of 1 to 8 days, and then fever begins, fever, malaise, and fatigue, body aches, very nonspecific symptoms, much like early influenza. In the gastrointestinal phase, there is a lot of epigastric pain, nausea, vomiting, and diarrhea, and as you'll see from some later data I'll show you, these particularly diarrhea and very bad diarrhea portends a very poor prognosis with Ebola. There's also the fever persists, there are neurologic changes and paresthesias, and more evidence of systemic disease. Hiccups is an interesting clinical feature that has been described in the second phase of Ebola. And then at that point, after that point, patients either get worse or get better. Those who recover have slow resolution of their GI symptoms and begin to take in fluids and keep up with their own fluid losses. Those who don't progress oftentimes to shock and coma. They may have secondary bacterial infections as a cause of death. And the late complications, GI hemorrhage, secondary infections, even meningoencephalitis, and some persistent neurocognitive abnormalities. So this is a complex multi-system disease that really, as you can imagine, in Western Africa, where the healthcare system does not have great resources in terms of supportive care, you can imagine that patients who are this sick do not have a very high survival rate. Welcome, welcome. So what are the symptoms like? This graphic from one of the presenters at the Infectious Disease Society meeting shows you in red Ebola symptoms compared to non-Ebola symptoms. And importantly, one, they overlap tremendously. There are none that are very specific. The few that make, meet significance, anorexia, right upper quadrant tenderness, conjunctival injection like you would see perhaps in Kawasaki disease, rash, some gum bleeding and bleeding at injection sites, but these only reach about 10% of the patients here and up to about 60% of the patients up here. And the asthenia is neurologic and sensory changes in the peripheral extremities. Again, very difficult to tell in a patient who is in shock or in a coma or unable to keep up with their fluids. They're not going to be telling you, yeah, my fingers are tingling. And so very non-specific symptoms overall. Some very helpful information has come from case reports, and this report in October in the New England Journal was the first case report of an Ebola patient who was treated in Europe, specifically in Germany, and that gave very specific details about the case. And this is day of illness here, starting at day 10. This was a reporter who was in Senegal who went to Germany for care. And you can see his temperature. He was febrile, well out past day 17, and a relatively high respiratory rate. O2 sats dipped down here in the mid-second week of his treatment, of his care there, as well as heart rate went up, and he had an increasing oxygen requirement. Over time, going out to day 27, he still was febrile for a while, then became afebrile, and then became febrile again with a secondary bacterial infection with gram-negative sepsis. Impressively, when you look at the amount of IV fluids they're giving this guy, 12 and 13 liters of fluid a day, because his diarrhea is on the order of 5 to 7 liters of diarrhea per day. So massive GI losses, which take with it the electrolytes and a good bit of vomiting, and obviously very little urine output here. So his positive balance, is very significant. 2, 3, 4 liters a day, up to 11 liters a day positive balance during the course of his ICU stay. They also provided us some information about the amount of virus that is being produced. And this is the plasma viral RNA level in the red line here. And you can see that it was down to undetectable by about day 17 and stayed that way. Here in the gray line is his white blood cell count, white cell count, and you can see it was low early on, as is not uncommon in more severe viral infections, peaked at about 8 and then went back to near the normal range. When it comes to viruses at other sites, again, here's the plasma viral level, viral load in red, and they also looked at his IgG antibody titers in green, so he developed a nice IgG titer, an IgM titer, and they demonstrated that his urine excretion of Ebola virus and also sweat from his skin continued to have titers of Ebola virus up to 10 to the 5th per milliliter of those body fluids. Whether that is transmissible virus is not clear. Whether that's infectious virus is not clear because, as I said, the viremia was long gone, but evidence of viral replication or at least shedding of the leftover DNA of the virus persisted even out to day 30 and 40. Since then, the more recent cases in Nebraska, the guys told us a couple of weeks ago, they elected not to even look at excretion of the virus in sweat and urine because they didn't know what to do with the data. Is it clinically important or not clinically important? And they have no clue, no idea. So some interesting findings when you can dig deeper and use high sensitivity DNA tests. Just published this morning in the New England Journal is 2 more case reports of patients who were treated at Emory. And the important points that I want to show you, this is one patient who got 2 doses of the drug ZMapp. And you can see here the blue line is his sodium concentration. But when he got to Emory, his sodium was in the 120 range. And it took them 3 or 4 days to get him back into the normal range for his sodium. He was also very hypocalcemic, and it took a good number of days to get him back to the normal range for his calcium. His albumin stayed low at around 2 and slowly crept up to about 3. So we're talking about some significant metabolic derangements. His liver enzymes were very high when he came in. After his first dose of ZMapp, the alkaline phosphatase came down, and slowly the other AST and ALT also came down and back to normal. And again, the white count here for him in the blue line was high early. We're looking at 16, 18,000, and then came back down to the normal range. Hemoglobin stayed fairly stable, although in both these 2 patients and the ones from treated in Germany, they were very hemoconcentrated when they got there. They had hemoglobins of 16 and 18 fairly persistently because of the volume loss and preservation of red cells. So overall, the Ebola case counts from West Africa as of a couple of days ago look like this. The total number of cases, 18,464. Laboratory confirmed are almost 2/3 of those. And the total number of deaths is right at 6,841 with an overall mortality rate of 37.1%. But you can see the mortality rate varies significantly between these 3 countries. Sierra Leone doing the best with about 25% mortality, Guinea doing by far the worst with about 63% mortality. Again, you have to take this data with a relative grain of salt because the reporting is difficult and the case counting may be difficult, and there may be other people who've died but just not died of Ebola, and their cases are not counted because they were at home in a small rural village and the epidemiologists weren't able to count their cases. But this also attests to most likely the difference in the ability of these countries to handle severely ill patients. And Guinea is an extremely poor country. None of the 3 of these are wealthy by any means compared to Western and US. There was a small epidemic of Ebola or outbreak, I should say, in the Congo this year with a total of case counts of 66 and 49 deaths. It was the same strain of Ebola that has been epidemic in West Africa, but this outbreak in the Congo was considered unrelated to the West Africa epidemic. So it was an independent outbreak, and the good news is that that has fizzled and is considered no longer a threat in the Congo. Again, another extremely poor country with very difficult social circumstances. So a little bit about Ebola. We're learning more as we deal with this epidemic, and there's still a lot we don't know about its transmission, but a key piece of it is the fruit bat. And for those of you who are infectious disease aficionados, you'll recognize that the fruit bat has been a recurring theme over the past 20 years for different emerging pathogens like Nipah and Hendra viruses that infected horses and then killed humans. Those are paramyxoviruses in that family, and other outbreaks of new novel pathogens. The fruit bat is an interesting player in all of these epidemics. And it's not clear whether the fruit bat is actually the reservoir or it acquires the virus from a different reservoir. We know that it can transmit virus in its feces to small ruminants and also non-human primates. And these are the likely source of transmission to humans. Humans are by far and away not a dead end for this virus like many of the other zoonotic diseases that we have, because human-to-human transmission is very easy to accomplish. The outbreaks, there have been over 20 outbreaks since 1976 when the Ebola virus was discovered, and most of these have been relatively small outbreaks. 280 is a relatively small outbreak. The outbreak we're in now in West Africa, the epidemic, is the largest of all the epidemics by far, and its numbers are greater than all the other outbreaks combined. So that tells you how big the current Ebola outbreak is. Here are the sites of those outbreaks, the current one showing here, and the size of the circles on this map indicate the number of cases, and you can see there are also different colors. The Zaire strain is the red, it's the most common, it's what we're dealing with now in West Africa, but there are other strains, the Typhorus strain and the Sudan strain over here, and the Bundibugyo strain also in Congo. So Congo and Sub-Saharan Africa, sort of the northern half of Sub-Saharan Africa is kind of a hot spot, and obviously West Africa now. But we've had a few cases as far south as South Africa years ago, and we are aware of the exported cases to the United States, to Nigeria, to Spain, and other places. Obviously not a surprise. Big question usually comes, how can this virus be transmitted? Virtually any bodily fluid can transmit the virus. Transmission of the virus is most likely to happen when the patients are the sickest. So either near the time of death or after death, when their viral loads are extremely high. And we know that in Western Africa, the burial preparations of patients with Ebola virus have been, the traditional preparations have been a very common source of transmission of the virus to others. We also have to remember that anybody who has direct contact with an Ebola disease patient is at risk. And so that reminds us of the healthcare workers in Dallas who were infected because of the patient there who had acquired the virus in Liberia. So secondary transmission. Healthcare workers become one of the more at-risk populations, maybe the most at-risk population in the United States, because we're caring for these patients, especially late in their course when they're very viremic. We've reviewed these symptoms already of clinical illness and outcomes. This breaks down fatal versus non-fatal Ebola virus. As I alluded to earlier, the black is the association with being a fatal outcome of Ebola virus, and the three symptoms that are associated with death are weakness, dizziness, and diarrhea. And obviously very subjective characterization of weakness and dizziness for the most part, but diarrhea is obviously easy to quantitate, and as I said, portends a poor prognosis for these patients. Other particularly interesting findings on the medical side for individual patients, again correlating with fatal and non-fatal cases, no difference in CO2 levels, alkaline phosphatase, liver enzymes, maybe some differences here, fatal versus non-fatal, and here increased creatinine, evidence of renal failure, renal dysfunction, correlates very highly with death in Ebola disease, attesting to the importance of having good care at a tertiary referral center where dialysis can happen. When it comes to treatment, there are currently no vaccines or Ebola-specific antiviral drugs that are FDA approved. There are many that have been in the pipeline and for development for more than a decade. And they're sort of just a little bit late to really change the tide of the current epidemic, although some of them have been used in individual cases. The ZMapp drug and a few other drugs are being used in the United States, but not in West Africa at this point. Antibiotics obviously don't work on viral infections. You're all aware of that. And passive immunization using blood plasma from patients who've recovered from disease may be helpful in the treatment. That's a classic passive immunotherapy kind of situation, and we're well aware of the reports in the literature of Dr. Brantley, who was treated at Emory, donating plasma for other patients with Ebola, and maybe that is helpful. It's not clear, no randomized data there. Sarah?
Do you have any information on whether or not those patients that have received immunization are covered against the other strains of Ebola?
So is there cross protection between the strains? We don't know the answer to that. And I think the supposition is that there will be cross protection to some extent, but the strains are different enough that it's likely there are unique components for the immune response also. We'll probably know more as our animal models begin to do cross challenges between strains, vaccinate with one strain and cross challenge with another.
I just heard something on the radio about someone who had been treated and they were going back because they said they were essentially immune.
Well,
maybe immune to one strain, but not necessarily.
Yeah, surviving one strain is considered to give you protective immunity. Obviously, you have some natural selective, inherent selective advantage if you can survive this kind of disease, especially in West Africa. But we don't know all the ins and outs of that immune response yet. All right, at Emory, this is what their biocontainment unit looks like. Single entry point, common area here, and individual patient rooms on the left and right with private bathrooms in each. And these are, high containment areas. And a nearby laboratory, you can see the guy here is wearing what we would traditionally call a spacesuit. It's much like what the orthopedic surgeons wear in the operating room with a big face shield and an oxygen supply or a clean air supply to prevent the transmission from patient to the caregivers. One interesting thing the folks from Emory reported after the two patients that they had and cared for that survived, after they were discharged from the hospital, before they totally decontaminated their unit, they went in and did surface swabs of high-touch areas, especially bathroom where there had been diarrhea and the like, and looked for evidence of the virus and were not able to detect virus in the environment. So that may give us a little bit of reassurance that the virus doesn't survive very well for a long period of time in the environment. We know that's temperature dependent, humidity dependent. There are a lot of factors there. Interestingly, also at Emory, you may have heard the reports that when the patient was expected to be there, the director of their biocontainment unit got a phone call from DeKalb County Water Service, Sewer Service, and asked if they were going to discharge Ebola contaminated sewage into the city system. And the doctor very prudently said, well, why do you ask? And the director of the sewage system's response was, well, because if you are, we're shutting off your water. And so it's well known that our routine sewage treatment practices are adequate to control the Ebola virus and prevent it from spreading in the community. And so CDC and the World Health Organization have not recommended anything above and beyond the routine. But what Emory had to agree to keep their water supply on was that they would treat any liquid waste with bleach for 5 minutes at least before they discharged it into the sewer system. So it's fear driving decisions that may or may not have a basis in fact or in reality. Happens all the time. They couldn't get the pizza delivery guys to deliver at Emory when the Ebola patients were there. So that gives you a clue. And even the FedEx delivery guys wouldn't take properly packaged samples from Emory half a mile up the street to CDC for testing because they feared the Ebola virus. So it's just what it is. Rational or irrational, it is fear, and fear drives a lot of things. All right, a little bit about the vaccines that are in development. I won't spend a lot of time. This is some data recently published, or this is 2012, on adenovirus-based vaccines protecting against lethal Ebola challenge in mice and guinea pigs. That's all well and good, but what about in humans? There are two major vaccines that are being in testing now for immunogenicity, and they've passed those immunogenicity tests with flying colors. One is a recombinant vesicular stomatitis virus, so this is a rhabdovirus in the family with with rabies that infects large ruminants, cows and the like, and it's a great virus for expressing foreign proteins. So the Ebolavirus G protein is, it's not a G protein, it's the surface protein, glycoprotein, was inserted into this virus, and it makes a very good vaccine. And GSK and the NIH are using a bivalent Ebola vaccine in an adenovirus, actually a chimpanzee adenovirus vector. These are also in human trials at this point in time. Early trials, immunogenicity, and once that data is fully vetted, it's likely that we'll have, within about 6 months, are the estimates, some vaccine for use in testing, early testing in the areas where the epidemic is still problematic. This is also interesting data where this adenovirus-based vaccine has been tested in non-human primates with lethal Ebola infection, and this graphic shows you the survival curve. 60% survival when patients got intranasal and intratracheal immunization compared to intramuscular, which gave about 50% survival, and sublingual gave you no survival at all with this vaccine. So we're not necessarily talking about injectable vaccines for all of these. Some of these can be given intranasally or intratracheally by other routes and give good immunity. All right. Let's see, we talked about, these are the predicted curves of the epidemics from CDC. These were published in October based on data up through September. And so their data line is the vertical line here in gray. To the left of that, they have actual data. And to the right of that was, projections of numbers of cases based on mathematical modelings. And this is what you heard a couple of months ago in the news media, projecting up to potentially 1 million cases of Ebola by January or February. Where we are in these case curves on the log scale, we're out here into November now. We know that the number of cases in Guinea has already reached 2,000. In Liberia, we've well surpassed the 4,000, as well as in Sierra Leone. And CDC has yet to update these models to say how well have they predicted what's happened in the interim. We're all waiting anxiously for an update from CDC on the case projections looking forward. But I think the epidemiology on the ground, as I showed you earlier, that the number of new cases per week has peaked in all 3 countries, gives us some hope that the tide is turning and that we're on the beginning to get to the downside or the plateau of the epidemic in West Africa. So what did it look like at Emory when the patients were there? Apparently there were more than 300 news crews and trucks there waiting for data every day on the patient. The good news is this is Dr. Brantley coming through the reception line with all the caregivers who took care of them. A very, as Dr. Ribner from Emory described it, just an incredible day to see this man who came in on death's door walk out to cheers of crowds of people who had cared for him, not unlike the heroes of the NFL or your favorite sport, coming through the tunnel and just an incredible day. He said there were tears of joy in everyone's face on this day when Dr. Brantley left their unit. So very rewarding outcome. The good news is of the 4 patients who've been treated in the United States, only 1 has died, and that we believe the patient from Dallas was primarily due to a late presentation of the disease for care. So that's a wrap on Ebola. Any questions on Ebola before we move to the other topics? They're much shorter and less intense. Dr. Bond.
You mentioned that the respiratory droplets is a method of transmission, whereas the news media will always say, don't worry about the respiratory tract.
How do we drive those 2 things? So part of it is semantics. From a physiology standpoint, when we talk about respiratory droplets, that's respiratory fluid that we cough up. It's large droplets. It doesn't say suspended in the air. It's like the difference between what you cough out and what you sneeze out. Both of those are respiratory droplets, but what we cough is much bigger than what we sneeze. the discussion of airborne transmission is it possible to transmit the virus in normal breathing in the same air as someone, not who's coughing and sneezing. The respiratory droplets that are on the list there, when they suction the bottom of Dr. Brantley's lungs, they got tons of virus there. Well, you have tons of virus everywhere. Think of it this way. If you take a bottle of Ebola-infected blood and throw it in the air, is it airborne? Is that airborne transmission? And the answer is no, that's still bloodborne, right? So it's somewhat semantics. The point, and what's been put forth in the media and CDC's been adamant about, is that in normal tidal volume breathing, you and I sitting next to each other having lunch, you may get flu from me, you may get adeno, para-influenza, all those things, but you're not going to get Ebola that way.
The airplanes crowded, and the people will sneeze or cough.
Right. You're right. There is still concern. It has not been fully dispelled whether there can be respiratory transmission. Again, the respiratory droplets we're talking about are somebody who's very latent disease, what they can cough out of their lungs. Normal tidal volume breathing, sitting here, you don't have to be worried about sitting next to the infectious disease doctor. See, Dr. Bocchini has to sit way over here. You're not going to get it from him, okay? I promise.
That's why I'm over in this corner.
Yeah.
But the other thing is that, that's why I'm over in the corner by myself. But the other thing is that the titer of virus increases significantly the more symptomatic a patient becomes, so that when a patient's able to sit next to you on an airplane and they're not vomiting, they don't have fever, they're not having diarrhea, their chance of having high titers of virus is pretty low. So the likelihood that's why under normal circumstances this virus is not going to spread in routine social situations. So the patient needs to be really symptomatic, and you need to be contaminated by the fluids to really transmit. So that's why it's family members, funerary practices, as John said, and healthcare workers who are the primary targets.
Okay, so this one, Dr. Bono, we're mostly worried for you because you travel to the Middle East, so we wanted to touch on the Middle Eastern coronavirus. This has been in the news in 2014 because there have been 2 imported cases of this Middle East respiratory syndrome coronavirus, or MERS coronavirus. The bottom line is that travel to the countries that are colorful here, Saudi Arabia, Yemen, Oman, UAE, Qatar, Jordan, and the others, Iran, Iraq, Syria, these are the major epidemiologic clues to risk for the MERS coronavirus. Now, what is this virus? Well, it's a virus that, and when you think of coronavirus, we all think of the SARS coronavirus from 10 years ago, and it's obviously in the same family. We know there are coronaviruses that circulate around to us, all the time as respiratory viruses, and these are just coronaviruses of non-humans, other mammals that happen to cross over into the human population. And when it comes to the Middle East MERS coronavirus, that transmission and the source of that transmission is the camel. And the epidemiology there has been fairly well worked out. This report in the New England Journal a little over a year ago, in August of 2013, reported a large hospital outbreak of the MERS coronavirus that happened in the Middle East. And it emphasized the importance of, again, what Dr. Bocchini was referring to, when patients are sick with the coronavirus, like others, they have very high titers of the virus and make transmission much more efficient because of those high titers of virus in the respiratory tract. And you can't read all of this, but the first 2 cases on the far left were community-acquired, and then all the rest to the right of the first 2 were hospital-acquired cases, including in orange the dialysis unit, and in yellow, this kind of pale yellow tan color, in the ICU, and the darker color in actually other hospitals B, C, and D in this large outbreak. So person-to-person transmission is problematic with this virus, again, when patients are very sick with it. And here's the transmission map. These are getting to be fun, where you see patient A, and they've transmitted to multiple patients who transmit on to other patients. And when you see the transmission maps for Ebola, it looks like a pot of spaghetti because there's so much interaction between all these people. And unfortunately, the same is true for our epidemics here of syphilis and HIV and the like. But they're kind of fun to look at. The outbreak that occurred in that hospital-based outbreak as of June of 2013, before it had fully resolved, 15 patients had died, or 65% of those patients had died with the MERS coronavirus. So that's a very high mortality of great concern. Transmission from human to human in social circumstances is apparently not a major problem. It is clear that it can happen, but it's really attending patients who are very sick with the disease. You're more likely to get it and spread it. Many of those who got the coronavirus in the hospital were healthcare workers and not other patients. And this is a long graphic that's interesting reading from June of this year on the evidence for camel-to-human transmission of the MERS coronavirus. And the bottom line here is if your camel has a runny nose, don't kiss it, okay? Just stay out of the camel's face. We don't want camel coronavirus infecting you. An interesting graphic here of the relatedness of the viruses. Here are the two coronaviruses, one from a camel, one from a human. Only one nucleotide difference between them in the segment that was detected or looked at there. But here, human and other isolates from different parts of the country, in these countries in the Middle East. So very closely connected, but camels are the source. And here are the health advisories, just like the questions we asked related to the Ebola epidemic. Have you been to West Africa with the MERS coronaviruses? Were you in the Middle East recently? You're looking for fever, cough, respiratory symptoms, and if you get sick within 14 days of leaving one of those areas, you should see your doctor and get treatment. And I assume this says the same thing, but I really can't tell. I'm sorry, my Arabic is pathetic. All right, next one, Enterovirus D68. This was a hot topic in the late summer. And you know that we have been interested in this and looked at some of our cases of enterovirus disease here and sent samples to CDC. This graphic from early November shows areas where the enterovirus was low in green, elevated or increasing more out in the west and up in the northeast. And we really haven't gotten a whole lot of new data since this time from the CDC. What we know, and you all know, is that enteroviruses are common each year, causing 10 to 15 million infections per year in the United States. And in the late summer and early fall, CDC and state laboratories confirmed a large number of cases of enteroviral respiratory disease due to Enterovirus D68. CDC was inundated with samples to test for this virus, and many were positive. They had about 40% of their specimens tested positive for Enterovirus D68. Of the 10 samples we sent from here, none of them were in fact Enterovirus D68. They were other enteroviruses, just not D68. And what we also know is that the confirmed cases this year have almost all been among children. Many of these children had asthma or a history of wheezing, and they seem to be the ones who are at a higher likelihood of being hospitalized or requiring intensive care. But this is not a new virus. And in fact, if you go back just a few years in CDC's information from 2008 to 2010, they published in 2011 data on Enterovirus 68 in Asia, Europe, and the United States. And you can see the states, Georgia, Pennsylvania, and Arizona, where cases were being tracked. These are small numbers compared to the epidemic we're dealing with now, but this was probably the precursor to the epidemic. The sort of emergence of this strain from the shadows several years ago spread, and this year became sort of an epidemic strain of interest. The virus was actually discovered in 1962. It's been known about for a long time. It's one of hundreds of enteroviruses that we're aware of, and the way I describe that to patients is that these are all like different flavors of ice cream. They're all ice cream enteroviruses, but they're just different flavors, and they taste a little different and act a little different, but they're very similar. They're much more similar than they are different. And this categorizes the enterovirus season in the blue panels here, and where the viruses, this D68 was detected in 2008 in the Philippines, 2009 into 2010, Pennsylvania and Georgia, and then later in 2010, Japan, Netherlands, and Arizona. So this is not a new virus, as it were. What's particularly interesting, though, about it this year in the epidemic is the reports of acute neurologic illness of unknown etiology in 2004, and then association of acute flaccid paralysis with anterior myelitis in California for over a 2-year period. And this is the epidemiology curve going back to 2012, 2 and 3 cases per month in California in 2012, a few in 2013, and more consistent 2 cases per month for 5 months in 2014. These are just the early clusters of this acute flaccid paralysis, which presents a lot like polio would. We know enterovirus is always in the differential for a polio-like syndrome. Remember, polio is an enterovirus, so it kind of makes sense. But also in the differential for this would be West Nile virus, which can present with acute flaccid paralysis. So the investigations from CDC have shown evidence that some of these cases in Colorado and in California have tested positive for Enterovirus D68 at the time of their admission for neurologic illness, and their further investigation, 64 cases were identified that met their case definition, and of these, they had spinal MRI, showed lesions restricted to the spinal gray matter, and rings a bell for one of the patients we've had on the floor recently, raising the question of, could this transverse myelitis in our patient be exactly this disease that has been reported? So we'll be looking at whether he meets the case definition and whether CDC should be notified there. Okay, that's D68 in a nutshell. Not a lot of new information since over the past couple of months. When it comes to avian flu strains, we talk about 2 that we're watching very closely. One is the highly pathogenic avian influenza. That actually means it's highly pathogenic to birds, but not so much to humans. And these are the case counts from around the world. Some of these areas have had very high case counts of 200, almost 200, with 165 deaths. So, high mortality rates. The good news with this virus is person-to-person transmission is not very efficient. These are mostly bird-to-human transmissions that ultimately, unfortunately, result in death of people. But human-to-human transmission is not very efficient. This virus is less worrisome than the next one I'll show you, because this virus is highly pathogenic in the birds. The birds are sick. And so it's easy enough to identify a bird with a runny nose, a duck with a runny nose, or a chicken. And what happens in those areas is they just cull the whole herd. They just get rid of the entire flock to eradicate the source of transmission to humans. Well, it's easy. You can identify sick birds, get rid of sick birds. The more problematic one is the H7N9 avian virus, which is considered low pathogenicity in birds. So the birds don't get sick, but they continue to have the virus, continue to shed the virus, and it can be transmitted to humans. Again, human-to-human transmission is not very efficient, and this report from the New England Journal shows 2 cases of patients with this H7N9 virus with acute respiratory distress syndrome, and again, a relatively high mortality rate. This epidemic, the first cases were in the spring of 2013. There have been 44 deaths out of 132 infections, so about a 30% mortality, but again, limited person-to-person transmission. The genetics of the virus put it in, let's see, it's going to be right here in the red ones. These are the H7N9 strains, and they're right among all of these strains from ducks, quails, wild birds, chickens, and the like. Here in purple are the H7N7 strains, excuse me, from outbreaks in the Netherlands, and down below in purple are H7N7 strains from the United Kingdom. So this is a highly reassortant virus that is a mutt of flu viruses, including elements from ducks, bramblings, other wild birds, becoming a reassortant virus with possible transmission to humans and a high pathogenicity. The complications are not unexpected for this virus. Patients of this is about the first 111 patients. The vast majority had pneumonias and acute respiratory distress syndrome, shock, acute kidney injury, some rhabdomyolysis in 10% of patients, and secondary bacterial infections. Again, no surprise with bad flu. A lot of these patients got anti-flu medications, and All of them required supplemental oxygen therapy. 2/3 of them required invasive mechanical ventilation during the course of their illness. And death was a problem for 27% of those patients, primarily from respiratory failure. Here's the epidemiology curve for these H7N9 cases. You can see in 2013, these are cases between the 8th and 17th week, so into the early spring of 2013, and then in the winter of 2014, almost a year ago, these cases began to emerge again in areas of China. And these are the areas where the earlier cases, you can see in Fujian province, a few in Hunan, and Zhejiang province here was the hardest hit areas for this virus early on. And when you shift to the more recent, you can see that the darker, it means more cases, and this virus has shifted, spread its epidemiology about, and Guangdong province is now sort of the hotbed for this virus with more cases in Hunan. So limited fairly well to China at this point in time, but again, difficult to deal with from an epidemiologic standpoint because the birds are not very sick or not sick at all. And the potential for export of those birds, you can see a few cases down here to Malaysia and other places where those birds are exported to. Go to the social media side, and what you see in gray back here is the case reports, and in black dots, the death reports, and it correlates well with the tweets about illness in the Chinese areas. So you can use your social media to actually get a good feel for where disease is happening. That's CDC is using this now to monitor respiratory virus detection and figure out where are the hot spots for problems in the United States. Before they actually know what the virus is, they can see an increase in talking about viruses, talking about being sick, friends in the hospital, all those kind of things. So some perspective, we know the case count, now it's over 18,000 cases. For Ebola, pandemic flu can be much more problematic and will be this year. We're expecting a fairly bad flu year. HIV, we have over 14,000 new cases in 2010 and over 15,000 deaths in 2010 in the United States. We know hepatitis C kills about 17,000 people a year in the United States. The endemic things that we deal with, syphilis being one I talk to you frequently about, are still much more problematic than these emerging pathogens I've talked to you about. And so we have to keep in perspective. We need to keep doing the things that we routinely do, looking for HIV, looking for syphilis, getting our flu vaccines, washing our hands, all of those things. Those are going to help us as healthcare workers not just protect ourselves and do better for our patients, but also be able to recognize something different like Ebola or the MERS coronavirus when it happens to show up in our emergency room. We know there are patients here that come to LSU every month from Liberia for treatment for chronic diseases. Well, they flag every time they answer that question, have you been to West Africa? The answer is yes. You know, the Ebola team gets right around them and they, you know, all those kind of things. They put them in a bubble, all those things. So we know that the risk is not zero. It's infinitesimally small. It's still fine to go to Dallas, right? But we as healthcare workers have to recognize that we are on the front line. We're the more vulnerable population for all of these strains. And all of them have shown up on our soils. The MERS coronavirus definitely has a couple of cases. The H7N9 has not, but other avian flus have, and bovine. All right, so here's our flu report for this as of December 6th of last week. The darker the color, the more activity there is. So this is obvious that flu is problematic in the South right now. And the nice thing is Puerto Rico moved over, so it's a colony of Louisiana now. So that's pretty neat. We'll get some more food for variety. Here's the local distribution map from the state. And we are region 7 up here in the northwest corner. And our levels now are considered medium high, 5 to 10% of reported case counts for influenza-like illness in our area. So we're seeing a lot of flu. Hospital data for the past 2 weeks was 20%, and then 10% of tests were positive for influenza. We're getting reports routinely from pediatricians in the community of 40, 50, 60 flu-positive patients a day in their clinics. I'm sure our clinic is seeing a lot of flu that they're not even bothering to test. When flu season is rampant, you can make the clinical diagnosis very accurately. So you don't have to wait for that test result. If it smells like flu, walks like flu, acts like flu, most likely it's flu. What else is going around? Well, this is again from the state. You can see in the pale green color, there's a lot of RSV here. There's a good bit of adenovirus. So adenovirus and RSV make up almost 50% of what's not flu, and another almost 50% is rhino and enteroviruses. So lots of stuff going around. Metapneumovirus here, here's the regular coronavirus, here's parainfluenza 4, 3, and 2. So it's a mess out there. You know, the toddlers you're dealing with are respiratory virus cesspools. Okay, wash your hands. If they start to cough, turn your head, get out of there. Don't take it, okay? Just say no. No? You don't have to wear a mask yet, but at some point you might consider it. Here's the flu epi curve for the United States. We're in the upswing, and what we're seeing is predominantly A strains. The light green here is B strains, and the A strains we're seeing, the ones that are typing, 99% of those are H3N2s. Ring any bells? Yeah, that's the one that didn't match so well in the vaccine, right? It was published just a few weeks ago. So again, lots of flu, not a great vaccine match, and so far only 7 pediatric deaths associated with flu this year. Laboratory confirmed cases, the highest case counts now are actually in the elderly, 65 and older, followed by the vectors that give them to the elderly, toddlers 0 to 4 years of age. So a lot of flu activity. Just advise any parents of young children to make sure if they're sick, stay away from grandma, stay away from grandpa, because they're much more likely to have complications of the flu. Here we are compared to the past few years. Since 2009, the pandemic strain hit early in the year. The past 2 seasons, 2012-13 in blue and 2013-14 in this light purple color, and the red triangles are our 2014-15 season. So we're marching up into the peak of flu season over the next 6, 8, 10 weeks. You should have your Tamiflu scripts on auto dial, speed dial. And across the country, there is widespread activity in the states that are colored brown here. And this is influenza-like, this is actually influenza activity, not influenza-like illness. So again, we're in the widest or highest levels of activity. In this map, Puerto Rico's over here by South Carolina. I just can't figure out where they're going to put Puerto Rico. All right, so that's your update for the day. Don't forget the routine stuff, but occasionally you have to think about zebras. And, you know, a zebra could show up in our emergency room. So be ready. Thank you.